I'd like to thank the organizers for giving me the opportunity to present on this topic at this symposium. So these are my disclosures. I do not have any financial conflicts of interest. I am an employee of the Cleveland Clinic, but all the opinions expressed in this presentation are my own and do not necessarily reflect the positions of the Cleveland Clinic on this matter. This topic has been surprisingly controversial, and because of that, it's led me to question what my understanding of vaccination was. And so I was comforted that my understanding of vaccination is that what is generally accepted. If you go to the CDC website, we see that a vaccine stimulates your immune system to produce antibodies exactly like it would if you were exposed to the disease. The World Health Organization website states that vaccines train your immune system to create antibodies just as it does when it's exposed to a disease. So the whole idea of vaccination is to produce protective antibodies without actually getting the disease. And so the question that naturally arises is, if I get the disease, do I actually need the vaccine? And if you understand what vaccination is, the answer to that for a reasonable person would be no. And so when this question comes up, if I have already had COVID-19 and recovered, do I still need to get vaccinated with the COVID-19 vaccine? It should come as a surprise when the answer is yes, you should be vaccinated regardless of whether you already have had COVID. And so try to look at the reasoning. The first sentence following that says that that's because experts do not yet know how long you are protected from getting sick again after recovering from COVID-19. Now, that is partially true. We don't know exactly how long you're protected, but there is good evidence that you're protected for several months and maybe a year or longer. And so the honest way to say that would be COVID-19 infection provides protection against reinfection with COVID-19. This protection lasts several months, maybe a year or longer. We just do not know how much longer. The next statement, even if you have already recovered from COVID-19, it is possible, although rare, that you could be infected with the virus and that causes COVID-19 again. So that statement explicitly states that if you have recovered from COVID-19, it is rare for you to get infected again. So when you look at these explanations, it's hard to square that against the recommendation that yes, you should be vaccinated regardless of whether you already had COVID-19. The last statement here, studies have shown that vaccination provides a strong boost in protection in people who have recovered from COVID-19. Yes, there is something to that, but there are nuances to this, and I'm going to explain that in a bit. So if you've given this some thought, you will realize that a recommendation to vaccinate those previously infected with COVID-19 makes two implicit claims. The first is that unlike what we know about infections in general, that is, infection provides some degree of protection against future infection of the same pathogen, there is something unique about COVID-19 that this is not the case. The second claim is that the second implicit claim is that people who are unable to mount an immune response when exposed to all the antigens of the virus during COVID-19 infection miraculously mount an immune response when exposed to the single antigen present in the vaccine. Now, these are both extraordinary claims, and you want to see if the data match those claims. One of the things that I want to point out before we go forward is that it is really important to draw a distinction between the immunological response and immunity. When we talk about antibodies, B cells, T cells, we're talking about the immunological response. When we're talking about immunity, we're talking about absence of infection or protection from infection. Now, immunological studies are extremely important in order to understand what is going on, the pathophysiological response in order to develop vaccines. But when we are trying to talk about immunity, we really need clinical studies. And so here is one of those clinical studies. This is a study where we wanted to see if people who've been previously infected need to get a COVID-19 vaccine. The Cleveland Clinic health system is one of our large health systems. We have many hospitals in several different countries. Within Ohio, we have a main campus, 8 regional hospitals, and many ambulatory health centers with about 52,000 employees. There are several things that happened after the COVID-19 pandemic hit us. One of the important things was that we started testing by PCR for SARS coronavirus. This was started on March 12, 2020. You have to realize that at this time, it was extremely important to have a healthy workforce. And so there were really measures taken to try to ensure that. All employees who tested positive were interviewed by employee health. When vaccines became available, vaccination began, and we started that on December 16th. It was initially the Moderna, we had the Moderna Pfizer vaccines. Both of those started within a few days of each other, and almost all our employees were vaccinated with one of these two vaccines, those who chose to be vaccinated. The second vaccine dose was scheduled for 28 days following the first one. So we designed this as a retrospective cohort study with where Cleveland Clinic employees were the subjects. The employee cohort was chosen because we had good documentation of vaccination and good documentation of infection. These were important data points that we needed to answer our question. And all employees at the Cleveland Clinic Health System working in Ohio on December 16th were included. That was the day we started vaccination. For the study, SARS-CoV-2 infection was defined as a positive nucleic acid amplification test. Positive tests within 90 days of the first positive test were considered part of the same episode of illness. A person was considered vaccinated 14 days after receipt of the second dose of the vaccine, which would have been 42 days after receipt of the first dose. And a person was considered previously infected if they tested positive for SARS-CoV-2 at least 42 days before the study start date. So our study went on from December 16th until May 15th, 2021. This was analyzed as a time to event analysis where the outcome was time to SARS-CoV-2 infection. We had a few subjects who received the J&J vaccine and they were censored on the date of vaccination. Those whose employment was terminated before the study end date were also censored on the date of termination of employment. For multivariable analyses, our explanatory variables included age, previous infection status, vaccination status, and slope of the epidemic curve. Now, it's important to understand that at the start of the study, almost no one was vaccinated. But as time went by, an increasing number of people are vaccinated. So if you look at any individual subject, their vaccination status would be unvaccinated on day 0. And over time, many of them would switch over to vaccinated. So because of that, we had to use vaccination status as a time-dependent covariate. And this picture explains sort of in a pictorial way what that means. So on the study start date, subjects were either previously infected or not previously infected, and that held for the entire study. So that was a fixed code. It was not a time-dependent covariate. But the vaccination status was people who were unvaccinated on day 0, and 14 days after they got their second dose, their status was changed from unvaccinated to vaccinated, and that was for both these groups. So effectively, the study design allowed for a comparison of vaccine effectiveness across 4 groups: previously infected, vaccinated, previously infected, unvaccinated, previously not infected, vaccinated, and previously not infected, unvaccinated. So 52,238 employees were included. You can see that these were mostly younger people. The mean age was about 30, close to about 40 years of age. The previously infected subjects had a high proportion that had patient-facing jobs, as expected, and not previously infected had a low proportion of patient-facing jobs. This shows the distribution across different sites. Of those vaccinated, 63% received the Moderna vaccine. And among those with previous infection, 12% did not have a symptom onset date recorded, suggesting that these may have been asymptomatic infections identified on pre-procedure or pre-operative screening. This shows the epidemic curve. It's important to understand this in the context of the study. And you can see that day 0, that's the start date of the study, was at the peak of our 3rd wave in Ohio. And these are the main findings in the study. This is a cumulative incidence curve. This is a Simon-Macher plot. And on the x-axis, we have the days since vaccine initiation date, so which means this is days since December 16th, 2020. And on the y-axis, we have the cumulative incidence of COVID-19. And we have these 4 groups. What this shows is that COVID-19 infections occurred almost exclusively in one group, and that group was the not previously infected unvaccinated group. If you compare among the previously infected persons, whether they were vaccinated or unvaccinated, there really was no difference. Out of the 2,154 SARS-CoV-2 infections during the study period, 99.3% occurred among those who were not previously infected or unvaccinated, and 0.7% occurred among those who were previously not infected who got vaccinated. But if you look at the 2,579 who were previously infected, none of them had SARS-CoV-2 infection during the study, including 1,359 who did not take the vaccine. There were limitations to our study. Our health system did not have a requirement for asymptomatic employee test screening, so it is possible that there might have been some misclassification about previous infection, mainly for missed previous asymptomatic infection. Our study included a working age population. There were no children. There were few elderly subjects. People had to be healthy enough to have been working, so probably the immunosuppressed population would not have been very much represented here. So we have to be careful about extrapolating our findings to the entire population. Asymptomatic infections would largely have been missed. And this study was done before the Delta variant was around. Now, acknowledging all those limitations, we could still conclude that individuals who have had SARS-CoV-2 infection are unlikely to benefit from COVID-19 vaccination, and vaccines can be safely prioritized to those who have not been infected before. I have to say that these findings should not really come as a surprise if we understand what vaccination is about. Now, are there other studies that suggest the same thing? I don't know of any other study that has done exactly the same thing, but I've pulled up some other clinical studies here. So this is a study that was conducted among employees of a SARS-CoV-2 testing company. And here the employees were really tested on a daily basis. And what this shows is that it compares the incidence of SARS-CoV-2 in people who were previously infected, people who were fully vaccinated, and those who were neither previously infected nor fully vaccinated. And again, what this study shows, similar to what we found, is that the infections occurred almost exclusively among those who were not previously infected or vaccinated. The incidence in the previously infected and the incidence in the fully vaccinated was very low and very similar, suggesting that previously infected and fully vaccinated people have about the same amount of protection from COVID-19. This is a huge nationwide study from Israel. It includes about 5.6 million individuals. And they were able to, again, look at the protection from vaccination, protection from prior infection in different age groups, for different categories here, for positive tests, for hospitalizations, for severe infections. And if you look at these numbers, you will see that protection from vaccination and protection from prior infection are really very similar, whatever groups you look at, and we are looking at the mid-90s range for almost all of them. This is a study that was conducted in Doha Airport, which is a large international airport in Qatar. And here they really looked at those subjects where they had documentation of prior vaccination and prior infection, and they were looking at the PCR test on arrival at the airport. And what they showed also is that protection from prior vaccination was about the same as protection from prior infection. So these are multiple clinical studies that seem to suggest that prior vaccination and prior infection offer the same amount of protection. And so you have to wonder why we still recommend that previously infected people should be vaccinated. And I've seen some explanations, and this is one of the things that I've seen. And so this is referring to one study where they found that in some military recruits in basic training, 10% of the recruits whose blood tested positive for COVID-19 antibodies before training were reinfected with COVID-19 while in basic training. And people conclude that these findings make a strong argument for healthy young Americans to get vaccinated. But look at what the study actually found. So here's the study, and yes, it is correct that 10% of the previously uninfected developed the infection. But if you look at the, sorry, 10% of the previously infected. But if you look at the previously uninfected, 48% developed an infection. If you look at the hazard curve, the x-axis is in weeks. So in 6 weeks, half of the previously uninfected persons developed an infection. And this is a very unusual setting. You really cannot generalize this to the general population. The other, another explanation that you hear is that natural immunity conferred from prior infection may not protect individuals against new variants such as the Delta variant. Now, this statement is absolutely true. There is no question that natural immunity conferred from prior infection may not protect individuals against new variants. There'll be less protection against newer variants than the original variants. There is no question this is correct. But as an infectious disease physician, I can tell you that I have seen a couple of patients previously infected who've come down with infection again, but I've seen far more patients who were previously vaccinated who have come down with infection. So it is a stretch to think that just by vaccinating, you're going to get rid of that particular problem. The reality is that we do not have any data that shows vaccination provides better protection than prior infection against the Delta variant. Now, this is the third point, that studies have shown that vaccines provide a strong boost in protection in people who have recovered from COVID-19. And that has been used as a rationale for why previously infected people need to get vaccinated. So this is what this means. So here is an example of such a study. This study examined antibody responses, antibody levels at baseline, after 1 dose and after 2 doses of vaccine. And you can see that in previously uninfected persons in green, after 1 dose of the vaccine, antibody levels increased, and after 2 doses, antibody levels increased even further. But in persons who were previously infected, antibodies levels were already high at baseline, and it increased after a single dose to levels that were comparable to what happened in the uninfected after 2 doses, showing that yes, antibody responses were boosted after a single dose. Now this again, I have to remind you, is an immune response study. It is not an immunity study. I can't jump to the conclusion that just because this happened, you need to vaccinate them. You could very well look at the same data and say that the people who were previously infected were able to mount an appropriate or a good antibody response when they were exposed to the virus, sort of proving that these people actually did not need the vaccine. And so you really need clinical studies. So here is one clinical study that has been widely circulated and has been widely proposed as an explanation for why. Sorry about that, I dropped my mouse. So for why previously infected people need vaccination, and this study claims that there was a reduced risk of reinfection with SARS-CoV-2 after COVID-19 vaccination. So let us see what the study did. The study examined all adult patients in Kentucky who had COVID-19 in March to December of 2020. The cases were those who tested positive again in May and June of 2021, and controls were those who did not test positive in May and June of 2021 in a 2-to-1 ratio, matched on age and gender. And the exposure examined was vaccination. And the study reported that those who were not vaccinated had a 2.3-fold higher odds of a SARS-CoV-2 reinfection. Now, it's important to understand that association does not equate causation. You have to have some biological plausibility. We don't see any biological plausibility here. But more importantly, let me go through what a case control study is. So what you do in a case control study is you identify cases. Those are people who've had a certain outcome. In this case, SARS-CoV-2 reinfection. Controls are persons who have not had that outcome. Now you want to have cases and controls who are as similar to each other as possible. And then you want to see what's different between them. So you see that, and so one of the differences between them is whether they were vaccinated. So let's call that characteristic A. And so if you find that characteristic A was differently distributed in cases and controls, then you conclude that the difference that you're seeing in the outcomes is because of the difference in characteristic A. Now, what if the cases and controls differ by another characteristic, let's say characteristic B? you can no longer be sure that the difference that you're seeing in the outcomes is because of the difference in characteristic A. So keeping that in mind, let's see what is going on in Kentucky at that time. So this is Kentucky. If you go back to December 2020, April 2021, and think of the population of Kentucky at that time. If you're following the news, you would know that people could be broadly categorized into one of two groups. There was one group of people who were more likely to believe that COVID-19 was a hoax. They were more likely to believe that they were not at risk for getting COVID-19. They were less likely to have observed masking and social distancing recommendations, and they were less likely to have received the vaccine. There was another group who were less likely to believe COVID-19 was a hoax, less likely to believe they were not at risk for getting COVID-19, more likely to have observed masking, social distancing recommendations, and more likely to have received the vaccine. If you think about this, the cases would have predominantly come from category 1, controls would have predominantly come from category 2. And yes, it is true that in category 1, they were more likely to have received the vaccine, but it is also true that they were less likely to have observed masking and social distancing recommendations. And so you can argue that this is what the study actually showed, is that that the people who had poor compliance with masking and social distancing recommendations had higher odds of SARS-CoV-2 reinfection. This would have biological plausibility. And so if you look at the write-up of this particular study, there's no mention of this major confounding factor. There was really no, the important thing also is that there was no explanation of multiple other studies that have shown the opposite and have been consistent with each other. So let me summarize the clinical studies that have compared prior infection and vaccination in protection against COVID-19. We have the study from Israel, the nationwide study with almost 5.7 million sample size. We have a study in Ohio. We have the study that was done in Doha. We have the study that was done in California. And all of these were really showed pretty much the same thing, that protection from prior infection and vaccination was similar, or something along those lines. The incidence of COVID-19 was similar in vaccinated and previously infected. Protection from prior infection and vaccination are similar. Previously infected gained no additional protection from vaccination. This study from the CDC was this was, as I explained, this was a seriously confounded study which claimed that those who got vaccinated had lower odds of COVID-19 reinfection than those who did not get vaccinated. So if you think about this, have people noticed that there is protection from natural infection?
Yes. You 2 minutes notice.
Yes. If you look at Israel, people are interested in getting back to life, living with COVID-19. For businesses to function, you do need to be able to have people moving in and out with some assurance that the people are moving in and out do not have COVID-19. And so there comes the idea of a green pass. And so this is a pass for people who have either been vaccinated or recovered. So there's the recognition that vaccinated or recovered seems to mean the same thing in terms of future risk of infection. That is Israel. This is the European Union, and you have a similar concept, the digital COVID certificate. And again, in order to get a digital COVID certificate, you need to either have been vaccinated, tested negative, or recovered from COVID-19. Again, the recognition that having been vaccinated and having recovered from COVID-19 really provide the same amount of protection. Now, this is valid in the European Union and in the entire Schengen zone. So immunity from prior infection. What we know about immunity from prior infection is that previous COVID-19 infection or vaccination confers substantial protective immunity against reinfection. What we don't know is the robustness of protection of natural, or for that matter, vaccine immunity against newer variants. So that is what we don't know, and we need to focus on studies to try to answer that. We also don't know how durable natural or vaccine immunity is. Now, when you say we don't know, this is one study that compared COVID-19 cumulative incidence of SARS-CoV-2 infection in people who were previously infected, called reinfections, and people who were not infected. And you can see that this is days on the x-axis. Even when we get too close to a year, the people who were previously infected seem to be substantially protected against that. So although we say that we don't know how long natural immunity provides protection, this seems to suggest that it is at least several months and maybe a year or longer. The important things about Delta variant infection, what we know is that among previously infected or vaccinated persons, a higher proportion than before are coming down with COVID-19 infection now that the Delta variant is the predominant circulating strain. What we don't know is whether the increase in infections is due to inherently weaker protection against the Delta variant from prior infection or vaccination, or whether it is due to waning immunity. And so as we look at studies that examine this, it is really important to distinguish between the two. Because if the difference is if the lower protection is because of waning immunity, giving a booster would make sense. But if the decrease is due to inherently weaker protection, you'll have to really wonder whether adding a booster is going to help that all that much. So it's time to question the wisdom of vaccinating those who are previously infected. We are wasting tens of millions of doses of vaccine on people unlikely to benefit. The vaccines are very safe, but they're rare problems, and we are giving an unnecessary risk of harm in people who do not benefit from this. And then also this would invite legitimate criticism when we say follow the science, because we seem to be in a situation where we follow the science when it fits a particular narrative, but not when it does not. And so we don't want to invite that type of criticism. And then with the whole thing about mandatory vaccination, if we are going to enforce mandatory vaccination without consideration of previous infection, we have to recognize that that particular practice is not based on science. So the key takeaways from my presentation are that people who have previously had COVID-19 are unlikely to benefit from vaccination. Prior COVID-19 infection probably provides less protection against the Delta variant than against the ancestral strain, but there are no clinical data to suggest that vaccination provides any more benefit. The duration of protection provided by prior infection is not known, but it appears to be at least several months and possibly over a year. And it is really important, we really need to emphasize that this is not an anti-vaccine message and should not be used as an anti-vaccine message. The COVID-19 vaccines are very effective in preventing severe infections and deaths. All unprotected persons should be vaccinated. Thank you, and I'll be happy to take questions.